Hi, everyone. It's Rebecca Emholz with the Mount Pleasant Chamber of Commerce. I want to welcome you to today's webinar, Living and Working During COVID-19, another series of The Pivot. And we're with the East Cooper Medical Center today. Looking forward to that conversation. And I always look forward to welcoming our moderator, John Carroll. John is the president of Unlimited Performance. He is a highly sought after expert who helps people, teams, and organizations be more productive, profitable, and have more fun. John is also a founding member of the Mount Pleasant Chamber. He serves on our executive board. How are you today, John?
Doing very well, Rebecca. Thank you. So good to see you this afternoon.
Good to see you.
Thank you for being the glue that holds all of this together. We're so grateful. And we welcome everyone to The Pivot, our weekly series of informational discussions on local, regional, and national issues in the midst of and following the current pandemic. This event is presented exclusively by the Mount Pleasant Chamber of Commerce. My role as moderator is to introduce our guests, get the discussion started with some questions, and give those attending the event live the opportunity to participate by using the chat or Q&A function, which Rebecca will be monitoring. We thank you for taking the time with your Mount Pleasant Chamber of Commerce to join fellow members in staying informed to help you care for your team, your clients and customers, and take care of business in post-pandemic conditions. We all know that healthcare in general and hospitals in particular have been put to the test in this coronavirus pandemic and shutdown. Today we get to meet two executives of one local hospital and learn how they and their team are addressing the increasing demands under these extraordinary conditions. Our first guest with us on this discussion regarding East Cooper Regional Medical Center during the pandemic is Patrick Beaver. Patrick Beaver took on the role of Chief Nursing Officer at East Cooper in May 2017. Beaver comes to East Cooper from North Shore Medical Center in Miami. Prior to joining North Shore Medical Center, Patrick served as the Chief Operating Officer, Chief Nursing Officer, and Vice President of Patient Care Services at East Liverpool City Hospital in Ohio. Patrick attended Fairmont State University and earned his Bachelor of Arts degree in English and received his Master of Science in Nursing degree from Florida Atlantic University. In 2010, he completed his Master of Business Administration in Healthcare from Waynesburg University. He is also a member of the American College of Healthcare Executives and the American Association of Critical Care Nurses. Patrick Beaver, welcome to The Pivot.
Hi, good afternoon. Thank you for having me and thank you for that introduction, Mr. Carroll.
Glad to have you here. I'm going to go ahead and introduce our second guest who will be joining us shortly. That would be Patrick Downs. Patrick Downs joined East Cooper Medical Center as CEO in March of 2017. As CEO, Downs is responsible for all hospital operations, executive planning, and medical services. He comes to East Cooper Medical Center from a sister facility, Coral Gables Hospital, where he also served as the CEO. Prior to that, he was Chief Operating Officer of Hialeah Hospital for 4 years. Patrick Downs also served as the Associate Administrator for Tenet Florida Physician Services and held the position of Associate Administrator at North Shore Medical Center. He earned his Bachelor of Science in Business Administration and Master of Science in Business Administration from Florida State University. As I said, Patrick Downs will be joining us shortly. He's coming out of another meeting. So Patrick Beaver, staffing, the first question is for you. Staffing, safety, the health of your team all come into focus under these unprecedented conditions. Talk about how you've been able to respond to the health and safety needs of the community while caring for your own people.
Yeah, I mean, for us, like the rest of the world, with our perspective being, I guess, exclusive in the healthcare space, it's new for us too. So we had to really get under the gun, so to speak, relatively quickly without a lot of information, try to determine, as we had at that point in March when we first started in this, conflicting information oftentimes from CDC, looking at World Health, trying to rely upon consistency, which presented discrepancies amongst various colleges, be it the surgeons or medicine. So again, I mean, very fluid, very dynamic, lots of unanswered questions, but we knew for sure that, across Europe, we had monitored it and watched it. Patients were some getting sick and some not, some dying and some not, so that we had to really create an infrastructure without truly much experience in implementing it, so that we could not only provide safe environment for the patients, but as you allude, had to provide safety for all of our staff, because they are of course, our only resource in a hospital, since we have no other goods to sell. It's our staff that really are the folks that keep us alive and well, so that we can care for those in our community to keep them the same. So again, it was a lot of engagement with staff members, really, somewhat exclusively initially our providers, that would be physicians, nurse practitioners, physician's assistants, and then the nurses themselves, really trying to come up with a platform that could accommodate rapid change, as information coming in was different, and also be able for us to really give them a sense of security, because, again, when we were getting inconsistent information globally, and actually, from our resources here, either in the United States, locally, or Tenet, lots and lots of panic. If you look at the profile of our average caregiver, they're of childbearing age for the most part. They may also be extended families taking care of their parents. So again, a dynamic a little bit different for me at this point in my career. We trial a lot in hospitals. We drill almost everything. Had drills a few years ago for Ebola, and while that is vastly different from a disease process and even maybe a response, we felt we were somewhat prepared, and then realized when the game changes every day, we're not as prepared as we think. And so again, our first out of the gate, when we got our first patient, was to try to create a structure that would ensure the safety of that patient. We had other patients in the hospital, so we have now what we think is a coronavirus patient, some others coming in that could be coronavirus patients, but also on a floor below, babies being born, patients with reconstructive surgeries that are already immunocompromised. So a team of us pulled together, and from early March through actually now currently today, we had our meeting. We implemented incident command. We came up with a list of questions, used the resources that we had available to us from the CDC, from our company. We have a great incident command still in place. We have at least weekly calls with them, helping us to really get a big picture. What are other health systems doing? How are we making interpretations of maybe conflicting information between our local departments of health across 80 hospitals, CDC, sometimes that not being consistent. So again, out of the gate, we created a unit that would allow our staff to easily wear the maximum PPE so that they could be safe. But all of our initial concerns, again, with testing consistencies, initially it was actually availability of testing. We were not really able to quickly determine what patients were of high suspicion or positive patients. So creating that environment that, number one, would keep us from giving the virus to other patients. But then again, I don't want to say most importantly, but equally importantly, how do we protect that staff member? We couldn't afford to have a workforce that diminished rapidly, because we are a small facility. And our whole community has really struggled. Patrick Downs and I attend weekly calls with other hospital leaders. I think a great opportunity for us to get together in what sometimes is more of a competitive environment, and really talk about how are we managing this for our staff, how are we managing this for our patients, which are our community. So again, I think an opportunity for us to network together, share best practices, talk about what wasn't working. I mean, we had our initial plans were to create a dedicated unit. When our capacity of virus patients, either persons of interest or known virus patients, exceeded that capacity, we had to come back to the drawing board and say, what next? are we going to be able to continue to provide all services, not only from a capacity perspective, but from a safety perspective for those patients and also for the staff. So again, it's still pretty fluid. We've seen decline of numbers, in our community, clearly, but we also are watching the resurgence of the pandemic right now across European nations. The World Health Organization has had a lot of statements, but one of the probably most frightening is that we would likely experience about 9 waves of this globally, and we would assume that we are most likely at the trough or the end of wave 1, so that would mean potentially 8 more. So we've learned a lot, but again, keeping that sustainable. We've had staff members out, really had to come back, to conversations on a daily basis, really engaging the staff. What do we need to do for you so you go home and feel safe? I mean, we've had staff members live in RVs. Initially, we had staff members leave their homes. They had concerns about taking it to their children or their significant others. So again, just a lot of our ability to listen to our staff, to really be in tune with the daily conversation of what was working and what wasn't. And I think the hardest part of that most definitely was the perceptions, because fear drove a lot of and continues to drive a lot of our perceptions. And I think for the first time with a younger staff, really the first opportunity we've had in healthcare to actually be afraid for our lives, while we've read about it, while we see these things happening maybe in other nations. At least in my career on this level, I've never had to actually be concerned about, can I go home and hug my child? I've had to worry about whether or not a pregnant nurse should even come to work today. So just challenged us again, and I think we survived, number one. When I say a local community at East Cooper, because we were all in it together. Lots and lots of conversations with staff, being at the front line with them every day. And again, really listening to them, what's working and what's not.
I'm going to pull off that mute. Patrick, that's an awful lot to take in, and I can't imagine. It sounds like you've gotten used to pivoting about every day, it appears.
Just about every day. I mean, it's a little less now, but we pivoted sometimes more than once in a day, and and trying to maintain. The staff look to us to deliver, of course, the truth, but also be consistent. And as a leader, I mean, we were unable to be consistent because the dynamic, as everyone has experienced, kept changing. So again, keeping that credibility to be a good leader and leading out front without having all the knowledge, I think also again was a challenge for our staff to trust us and ensure that we would do the best thing for them as we knew what it was that day.
Don't know if it's a fair question, and if it's not, say so, but can you characterize or describe for us what a wave looks like in your meetings?
A wave for East Cooper, or a wave in general?
Both, if you know, please.
Yeah, I mean, so across our community, we are probably one of the smaller facilities. We look at Roper and their 3 hospitals, as a system. We look at Trident and their 2 hospitals in MUSC. So we're not even remotely their size. So a wave for us looked vastly different for those hospitals. And again, that was information we shared every week. But we would get clusters of patients to come in. We thought when we got up to about 7 patients that were known positive, with 3 or 4 patients that were still persons of interest. We didn't know yet that might be our tipping point. And then we would have patients either rule out or patients that would discharge. So again, we tended to see initially those patients flood in, relax a little bit. Then we very rapidly, over a period of about 48 hours, reached our capacity, or our max, I should say, which was in the 24 range. And so again, those, when you asked me to describe a wave, they were different. The wave may have been an ER influx, or it may have been an inpatient concern that we had to manage.
Thank you. And we welcome Patrick Downs. Patrick, thank you so much for taking the time to be with us today.
You're welcome. Sorry I was just a little bit late. And I thank Patrick for starting the first 15 minutes of this. Thanks for having us.
Yeah, I'm so glad to have you. And we've introduced you already, and wondered if you wouldn't mind jumping right in. I've got a couple of questions for you. The first one is the coronavirus and the resulting pandemic has turned many of us into statisticians. Can you share some numbers of significance from the East Cooper Medical Center and or Tenet Health since cases of the virus have arrived in the Low Country?
Yeah, I mean, I guess, so the question is how kind of are we using statistics to gauge the spread, and, how is that kind of changing our world? So, I mean, we look at public data like everybody else. The state of South Carolina publishes their daily infection rates. And frankly, we get that sent to us directly, and it kind of gauges, obviously the spread in the area. Now it is statewide. And so, Charleston, as many of you know, was, Florence was really the first area to kind of take off with spread, but then Charleston shortly followed. And so even though the state was essentially spreading, a month ago, Charleston started to retract a little bit. So we look at both, state published data and then local data. And frankly, this was kind of a unique opportunity for at least myself and the other administrators in town to get pretty close. And, we started a series of conference calls between myself and Pat Cawley at the Medical University, Scott Isaacs at the VA, and Anthony Jackson at Roper, and Todd Galati at Trident. And, after the very first conference call, we said, we realized we're probably the most knowledgeable people in the community on the spread and what we're seeing after that one phone call. So we all agreed that we would, start a group text message, and every single morning we would send to each other what our infection rates are, what the hospital census is, and what our challenges are. And, really in real time at, 7 o'clock in the morning, I'd pull up my cell phone and I could see really what the spread was happening in the community. So as you all know, if you go back a month and a half, 2 months ago, we were at our peak of wave 1, and it wasn't insignificant. I'll tell you, probably East Cooper on a late Friday hit our breaking point. Roper certainly did. They had to, cease and desist all scheduled medical work at the hospital. It got pretty serious. I'm excited to say that now because, a month removed from that, it's looking a lot brighter for us in this community. So it's kind of we got a whole bunch of other statistics too, total infection rates, the positive rates that we see for admitted patients, the positive rates we see for anybody who presents to our ER who's symptomatic, discharged home. We also do COVID rule-out tests for otherwise healthy patients trying to access elective surgical work, which to me was always reflective of, how many asymptomatic carriers are there out there. And that was always between the 1% and 2% range for us. So yeah, a lot of data being thrown at us pretty quickly.
So, and in the middle of trying to operate a healthcare business, you've got people that want to come in and use your services other than the urgent care connected with the virus itself. How do you manage all of that?
Well, your priority is caring for your priority is caring for your staff. You need to make sure that you're able to keep your staff safe before anything else. And then once you can do that, then you need to care for the patients that are COVID positive and need hospitalization. And if in doing both of those things, you still have capacity to do elective scheduled work, then you owe it to the community and your staff, frankly, to continue doing that. Like I said, we did get close though. I think at one point at East Cooper, we had 15 positives in the hospital, and another, we call them PUIs, so patients under investigation. So we had, and anyone, I think it was about 21, 22 on that late Friday afternoon of patients you suspected having COVID positive. And at a relatively small community hospital of ours, that's pretty significant.
Wow. Okay. What an interesting development to get all of the chief executives together to share that information. That becomes a a valuable thing for the overall community, I imagine, at that point.
Yeah, it was a cool dynamic. I mean, you know, at the end, you know, we're competitors in a certain regard, right? I mean, we all, you know, have similar service lines, and but to see us all kind of come together and collaborate and plan, you know, resources started to get extremely tight too. So it was, you know, does anybody have ICU staff that you could float over to our hospital? The medical university ended up partnering with us. You know, testing was a big issue where people just we didn't have rapid tests in the hospital because the novel virus, and we didn't know how to test for it. And so the medical university was the first one to get that online and then offered it to the community hospitals, Trident, VA, us, Roper. And so for our high risk patients, at one point, we were all sending our labs to them, and they were giving us pretty quick turnaround. So, you know, we're competitors by nature, but at the end of the day, you know, it was, you know, we're in a crisis and we need to work together.
Fantastic. Glad to hear that. Thank you, Patrick. Patrick Beaver, let's come back over to you. We've heard some stories of healthcare heroes locally and around the globe. What are the top 2 or 3 examples of heroes in your midst through the pandemic?
Yeah, I mean, in addition to my role here at East Cooper, I'm also the chief nurse executive of our other hospitals. So, I mean, if there's anything positive out of this for me personally, it's sort of been that reaffirmation that people that go into this are into healthcare for the right reason. So I'll give you 3 examples of what I think were stellar from our community, however, in our hospital. Our ICU nurse that cared for, and I can't use names because I don't have their permission, but that cared for our initial patient actually became a patient also. But despite, you know, the fear, and this was in March. So again, if you think about, you know, coronavirus in the United States, that was early. That was about a month after New York started seeing, you know, patients there. And again, you know, despite fear, and despite us having that changing story that we already discussed, not only did he take care of that patient with the highest standard, he took care of that patient every day. He also took on the responsibility of putting himself with extra days and extra, you know, shifts to come in and teach other people how to take care of the patient. You know, was very much an obstacle in not allowing someone that may be, you know, a pregnant patient to go into the room. So again, I think just went above and beyond, despite the fact, and again, ultimately this nurse ended up, you know, having the virus, ended up recovering from the virus, and when they came back to work, acted exactly the same way, despite the fact that we know that it's still inconsistent whether or not you could be reinfected twice. So again, I mean, somebody that, you know, is this community, is part of this community, and really took care of the community. The other is a little bit, you know, different and maybe a little bit more sober, but because of the economic challenges we've seen across our community, not just, you know, people at our hospital, we had a family that experienced a loss. It was not a COVID-related loss, but one of my social worker case management nurses, you know, really had almost come to the end of all of her resources in which to help this family. The family had been affected by coronavirus, both economically and with illness. And you know, prior to us actually at the very last minute getting an arrangement, that nurse assured that family that there would be final arrangements made. And we found out that that nurse was going to take on that financial responsibility herself, so that family would be able, despite the fact that everything is different and we are not able to pay respects, our final respects to families, she was not going to have a family have that additional stress. So, you know, thankfully we found some other resources, but again, I think just an above and beyond experience of which we have just tons of them. You know, every day here at East Cooper, we celebrate them every morning at 8:15 because there's lots and lots of stories. The final is, you know, an ER nurse, again, takes care of elderly parents, extremely concerned about, you know, taking the virus home. I really think that the ER is probably one of the scarier places when you talk about the fear associated with COVID, because we don't know when someone comes in without symptoms that are typical to COVID, whether or not, you know, they could be a patient that is either infected and or is carrying the infection. So while we protected all of our staff, this is a nurse who, again, volunteered, and said, moved out of the house, lived in a makeshift apartment above the garage of his house so his parents could stay in his house, never missed a day of work, and every day came in, volunteered every single day for the known patients that came in, that he would take care of those patients because he had less to lose than some of the folks in his department. So I think 3 acts of selflessness that, honestly, I think is East Cooper. I just think these are examples that have really come out of this that, we could go on and on and on. I think everybody that works at our hospital, I gave you very clinical specific, are heroes, from our environmental staff to our nutritional staff, our leaders who have been supporting, all of their staff. Just a group of people that are committed to providing excellence in this community.
Hey, John, you're on mute.
John, there you go.
Those are the kind of people you like to work alongside, aren't they, Patrick? Those are great stories. Thank you for those examples. Patrick Downs, back to you. Much has been said about the value of leadership in times of difficult circumstances. And if you would, share a few observations from your perspective that have impacted the style and substance of your own leadership.
Yeah, I guess I don't want to take too much credit for leading through this. I guess to Beaver's point, to be honest with you, one thing that's cool about my job is caregivers just have this intuition to care for people. And so you kind of, as leaders of the hospital, you stress on whether or not, people are going to get scared, if they don't want to go to the hospital, if they don't feel like they're protected at the hospital, are we going to have people walking out, all of that kind of stuff. I will tell you that, nurses, technicians, they're resilient. And if somebody needs to be cared for, they completely rise up. I think one challenge we had as leaders was, this was just a never always changing environment, including today. And you subscribe to the belief, you over communicate, you give as much communication as you possibly can. And the challenge we had is we would communicate, and then within 48 hours, we got to retract what we said because there's another thing going on. I'll tell you a simple example. Like I said before, we didn't have testing. And so everything was having to be sent out to the medical university or LabCorp. And then finally, we get the BD Max, rapid test. It's got this 4-hour turnaround time. Thank goodness we get this thing in here, and we start running tests on it, and we communicate that to the medical staff. This thing is great, blah blah blah. 4-hour turnarounds. We get notified by the FDA that BD Max has a 3% error rate for all positives, which frankly 3% to me sounds like a pretty good rate. But we took the FDA said that they want all positives being run by the BD Max to be rerun for accuracy. And so our 4-hour turnaround turned into a 20-hour turnaround because you're running this thing twice a day for all positives. And so it just, it's just one of those examples where you communicate and then you almost have to quickly pull it back and say, sorry, we're not going to be able to match the turnaround times we gave before. But I don't know. I guess I give, you got to give the staff a heck of a lot more credit just for being who they are and being care providers throughout this whole thing.
What will you look at differently? What will you never see the same way, quite the same way, as a result of this, Patrick?
Shaking hands. I don't know if you're like me. I've been watching like movies and I'm judging people on the movies. Like, why are there so many people together? Like, I don't know. It's. In the hospital environment, the thing I love about my job is it's always changing. I learn something new every single day, and I'm not clinical. Patrick's clinical, and I rely on him for all of that stuff. But I've learned a lot through this, that's for sure, and everybody has. I've also learned everything I learned today. When another viral outbreak happens 5-10 years from now, I can throw it all out the window because it's going to be something completely different. So I don't know.
Yeah, we never thought. I guess in my career, I have just taken basic personal protective equipment like a mask or a surgical hat for granted. I think we've probably produced a ton of waste across the years that I've been in this business, and we won't take that for granted, because when we were close to running out, or worrying about where we might get the next basic simple equipment to keep our staff safe, it's made me look at those things we took for granted very differently.
It actually, to that point, that's a really good point, because normal hospital protocols, anytime somebody walks into an isolation room, put on an N95, and then you discard that N95 as soon as you leave. Well, that, for a patient in isolation, I'm looking at Patrick to fact check me, but that would create a burn rate of 40 N95 masks a day on a patient in isolation. Today, because of our PPE conservation strategies, which is still a problem, we're burning through 6. So we've now told the staff, you're not going to discard this thing. You're going to put in a brown, first off, you're going to wear it all shift, essentially. Don't touch it. And then you put it in a brown bag, because that allows it to air dry a lot better, and you're going to reuse it at a later date. And then we reprocess them. So yeah, the amount of waste that we've had in, healthcare in the past, kind of, you realize there's other, maybe better ways to do it.
Wow. Wow. And there are dozens more stories, I'm sure, where those come from. Let's get Rebecca in here. Rebecca Imholtz, a question from you or from somebody attending live.
All right, thank you so much, John. And hi, Patrick. How are you? Both Patricks, and it's nice to see you, Mr. Downs.
Good to see you again.
Nice to see you again as well. So this question is really apropos because of the stories that Mr. Beaver shared regarding, they're very humbling, your medical staff, the acts of selflessness that we all know our medical folks are doing these days to keep us healthy during this pandemic. So how is East Cooper Medical Center engaging new graduates of nursing and other healthcare programs to come work for you to help fight the pandemic? How are you doing that?
Yeah, so it's actually a good question, because when we ramped everything down, like in the whole society, we took this major approach, and we cut out all visitation at the hospital. Only necessary medical professionals and patients need to be entering into the hospital, and that included students. So we said, we do not need students coming into this facility, shadowing, learning. This is not the time for that. Certainly don't need them accessing COVID positive patients, burning through our PPE unnecessarily. Well, now that's evolved, and it evolved, frankly. And even if you remember, at that time, we weren't even going through a wave in Charleston at that point. So you fast forward to June and July, when we're in the midst of this major wave, and we've revised our visitation policy, so we now allow one person to come to the hospital. Well, we started to realize we're not in this for the short term. This is the long term. And any decisions that we make, you got to think about the sustainability of just working in this new environment. So we owe it to those students to be a part of their education, because those students are going to be our employees in the future. So we've still restricted it, but we said, nope, students need to start coming through the facility. You have one student per physician. I think we cap it. You can't have any more than a certain amount of students in the hospital at a certain time. We've tried to partner with the schools and say, our PPE is valuable to us. So if you're going to have your students come, please purchase N95 masks on your own, or any kind of mask to protect them. But we shifted from this, nobody can come in ultra conservative, to nope, this thing could be around for another year or two, whatever it is. God, hope that's not true. And we need to partner with them. So. John, you're on mute.
Sorry, Patrick, what would you add to that?
I'm sorry?
What would you add to Patrick's thoughts on?
Yeah, I mean, I think, I talked a little bit about that incident command. I mean, as leaders and also engaging our staff, we've tried to create a mindset and culture shift. And that is one part of it, that we need to think about: how do we take care of patients? How do we continue to build services, provide care for all patients, and manage coronavirus? So our decisions, and I probably make a lot of people crazy, but I'll ask, when we're trying to think sometimes to respond to an issue today, are decisions sustainable? Do we see ourselves doing that a year from now? And I mean, we don't come up with, as leaders, honestly, the right way to do things. We just guide and facilitate the discussion. Our staff give us the sustainable long-term results. And again, I will likely be dead or retired before a lot of these students, come into the workforce. But as Patrick said, they will be the folks that care for me. So my obligation is to give them the opportunities and the resources to be able to care for me well when the time comes. So, I think that's just what we see at East Cooper. The desire of our people. This is their community. They're proud of this community, and they're going to take darn good care of this community.
Thank you. Patrick Downs, CEO, it seems like you just joined us, but I'm going to ask you for a final thought on everything that has happened and maybe something you'd like to leave with us.
Wow. So, so I've been here for about 3.5 years now, so still pretty new to the Charleston area. I came from the Miami-Dade market down in South Florida, and I will say, just in general, not even COVID related, but the medical community in Charleston is spectacular. I mean, they're very good physicians. There's perfect coverage. 99.9% of any medical need you have in this community can be handled by the hospitals in this community. So I don't know. I mean, I'm happy to be here. I hope I'm here for a really, really, really long time. I hope you guys believe in, if I can give the shameless, East Cooper's the best hospital in the area, and we are. I believe that. But it's a really good team. Awesome. And I really mean that, awesome medical community. My family, I access care with our physicians at this hospital. And so I love Charleston. I'm not leaving. I love it.
Thank you. Thanks, Patrick, so much for being here with us. Patrick Beaver, a final thought?
I mean, I think I'd have to echo a lot of what Patrick says. I know that having been through this hospital, because of the people, again, at the front line, are going to be able to adapt not only to this particular situation, but as we see, new things come down, whether it be a different, medical emergency, a dynamic change in the community, a disaster in the community, the folks that are at this hospital are committed and capable of managing any situation to drive outcomes that I'm extremely proud of in our community, and most importantly, our patients that are our customers can count on when they come for services at our hospital.
Thank you, sir. Thank you, Patrick Downs, CEO, and Patrick Beaver, Chief Nursing Officer at East Cooper Regional Medical Center. Thanks to all of our chamber members with us live and those catching us on the recording. And a big thank you, as always, to the Mount Pleasant Chamber's own Rebecca Imholtz for keeping us on track today. From all of us at Mount Pleasant Chamber, thank you for joining us this week for The Pivot. Make it a great week.
Thanks for having us.